welcome to our webinar, so to speak, about best decisions and coming from being your own best advocate. We have a great panel here today that we're going to discuss the important decision about fibroids and the management of fibroids and what things are important to watch out for when you're approaching your gynecologist. I'm really glad that we have an excellent panel here. I'm going to serve just as a moderator to facilitate the discussion amongst the experts here. We have Margaret von Maren, a medical oncologist from Fox Chase Cancer Center, Suzanne George, who'd be joining us in a bit from Dana-Farber, also a medical oncologist, and Melissa Burgess from the Hillman Comprehensive Cancer Center from the University of Pittsburgh, also a medical oncologist. Then we have Amy Crago, a sarcoma surgeon, and she's joining us from Memorial Sloan Kettering. We have Aparna Kamat, who is a gynecologic oncologist from the Houston Methodist Medical Center. And we have Inga Marie Schaefer from Brigham and Women's Harvard Medical School, our expert pathologist, to give us some insights. We have Priya Bhosale from MD Anderson. She's our radiology expert. And we have Cecilia Bloom, who's a nurse navigator at the Houston Methodist Hospital. And we also have in our panel, Nikki Hughes, who's a patient and also an RN by profession. So I'm looking forward to a very robust discussion about the topics. These are some of the topics that we'll be discussing. So without much ado, we will jump in to the most important discussion regarding the options to treat patients with suspected fibroids. So I'm going to direct kind of the first question to our gynecologic oncologist, Dr. Kamath, about, how do patients present? I mean, incidental versus symptomatic, and what options would they have in terms of management of their fibroids?
Thank you so much for including me in this panel. This is a very topical, topic to discuss. So fibroids, I'm sure, you've probably have someone, a friend, a family member who suffers from fibroids. The reason that is because they're so common. Among white women, the lifetime risk is 70%, and it's about 80% lifetime risk of developing a fibroid if you're a Black woman. So it's an extremely common situation. It doesn't always need treatment. For example, fibroids can be found incidentally and may actually just they're benign tumors. They could be present in the uterus and may completely be indolent, not cause symptoms. And these are patients who don't really need any intervention. When fibroids become bothersome, the issues that women usually have is bleeding. So abnormal bleeding, either heavy bleeding, pain with their periods. They could have bleeding in between their periods. The fibroids get really large. Then they start developing symptoms where they start pressing on some of the organs which are around the uterus. So the bladder is right in front of the uterus. So if fibroids get big and start pressing on the bladder, then a lot of my patients will complain that they have a lot of frequency, in the sense they have to go and urinate very often. That's because the minute the bladder gets full, even a little bit, the fibroid, the enlarged uterus, starts pressing on the bladder. If they get enlarged and start pressing on the rectum on the back, then women can suffer from constipation or pain when they have bowel movement. So there are many, many different symptoms that can be associated with fibroids. So like I said, there are some fibroids which could be potentially just watched and managed expectantly. But when fibroids start causing problems, there are many, many different ways of treating them. There are medical treatments where we actually treat fibroids giving medications. So some women will get birth control pills. The reason is because fibroids actually grow under the influence of estrogen. So there are hormones that the ovaries produce. And that's why we see a huge increase in the size of fibroids during pregnancy when there's a high level of estrogen in the body. So we usually give medications which actually counterbalance the estrogen, so which is mainly progesterone. So medications which are high in progesterone, these can be pills, these can be injectables, but these are usually short-lived because they kind of control the size of the fibroid only while being taken. Then there are other options which are more trying to actually ablate the fibroid non-surgically. And so that is where if women don't want to get pregnant anymore, we can actually embolize the blood supply to the fibroids, so actually kill the blood supply. And because by doing that, can limit the growth or actually shrink the fibroids. That's called uterine artery embolization. There are other new modalities that have come out. There's something called magnetic MRI guided focused ultrasound, which can produce very high level ultrasound waves and actually destroy the fibroid. And then there's also ablation of the fibroid using ultrasound and laser. So these are the non-surgical techniques, but majority of women will actually have some sort of surgery. So when fibroids become very symptomatic, they can be treated, or if they fail some of these prior treatments, they can be treated with surgery, either a myomectomy, which is where we remove just the fibroid, and that's usually reserved for women who actually want to preserve the uterus. So in the sense, those who actually want to try to get pregnant and are interested in having children in the future. And obviously the definitive surgery is a hysterectomy.
So, Aparna, again, before we continue, I just wanted to let any of the audience know that please put in your questions in the chat box, and we will try to answer as many questions as we can towards the end of this discussion. So, Aparna, you did bring out a lot of different modalities and the way, gynecologists can approach fibroids. One question was, when they present with symptoms, going into what imaging modalities do you normally recommend? And maybe I can pose this question to Priya on the panel, and both of you can comment on what imaging would you recommend before they undergo a localized surgical or non-surgical approach for the treatment of their fibroid.
So I can just from a clinical point of view, address that, and then Dr. Bhosle could talk a little bit more about the different modalities. But when most women come in to be seen for fibroids, they usually, the first thing we do is actually do an exam. We actually, do a pelvic examination, kind of try to gauge how big the uterus is. And then after that, the most common modalities of imaging are a pelvic ultrasound to kind of evaluate the uterus, the tubes and ovaries, but also to kind of see how many fibroids there are, where they're located, and to get a little bit more delineation of the fibroids. One of the other modalities that is very commonly used is an MRI. So those are the two main go-to imaging that I would recommend.
And I'm just going to bring up, I just saw a patient on Monday, and it was kind of a sad case because she had presented with pelvic symptoms almost 2 years ago, presented to the ER. The ER did a CT scan, told her it was fibroids, sent her home. A year later, she presented with exactly severe pain, symptoms with bleeding, presented to the ER. Imaging was done. They told her it was fibroids. That imaging also caught actually a lung, very circumscribed lung, nodule, which they called her and told her later about, but didn't make much of it. And this year she presented with lung symptoms with just sinus infection and has a lung full of mets. And so the question is, Priya, I don't know if you can comment on this, when you have a CT scan, they're told it's fibroids, is there something else they need to be looking at? And what do you look at when you look at a CT scan to determine what are the red flags?
So when you look at a CT scan, you're looking for the lesion itself, whether it's enhancing, whether there's central necrosis. Most of these fibroids, they have a typical appearance, and I can show you some images which may help you understand that how difficult it is to differentiate a fibroid from a leiomyosarcoma or a sarcomatous tumor which can arise from the uterus. Dr. Samaya, do you have the slides, or should I show it?
You can try to share it automatically. That way I'm not, but if you can't, I will pull up your slides. Let's see here. Otherwise, let me do it. Oh, there you go.
So can you see the images?
Yes.
Okay. So on a CT, a fibroid will look like a solid mass within the uterus, and it does enhance. So we do recommend MRIs if you have many fibroids. As you can see here, this is the uterus with large dark dots within them. are large masses. And they all look kind of the same. They're all black on the MR. We have different sequences to figure out like what is a characteristic of this mass. So if it does look like a dark ball on the T1 and the T2 eta sequences, then we most likely call it a fibroid. And currently we've had different sequences, newer ones, which have come through, and we're utilizing it, and they're called diffusion and ADC maps. The diffusion will look at the cellularity within the tumor. If the tumor is tightly packed, on the ADC maps, it will look totally dark, and we can tell that it's a fibroid. So what happens is sometimes it's a cellular fibroid and an acellular fibroid. And I'm going to show you an image of a sarcoma. The sarcoma will look like this. It's a large mass which enhances. On the imaging, it has different color as compared to the other one which we saw, and it's pretty easy to diagnose that this is a fibroid. And this is a diffusion sequence and an ADC map. So you can see the areas, black areas, they're highly cellular areas, and the bright areas are non-cellular areas. So now what the confusion is sometimes these fibroids may undergo degeneration and they become fluid-like. And this could look like a fibroid in a sense. A fibroid could also look like this in some cases. So I'm going to show you an example here. This is a patient with a leiomyosarcoma, and you can see mets in the lungs. So this is another patient with a leiomyosarcoma. You can see it's dark on the diffusion. You really don't see on the T1 weighted sequence. It has focal areas of enhancement, and on the T2 it's dark. So it's kind of difficult sometimes to tell them apart on imaging itself. But what we do see is if it's growing fast over a short period of time, if it has increased vascularity and within a few months it starts degenerating, then we can call it a leiomyosarcoma. Now this is another patient who has a mass within the uterus. This was just a fibroid, and on imaging, it has the same characteristics or like the aggressive features which you saw in a leiomyosarcoma. This is heterogeneous, it does enhance, it is bright on the diffusion and dark on the ADC map. And I'm going to show you the first one and the last one again together, and you can see that it's very difficult to tell. However, the patient's symptomatic, it's grown really fast. If you see this in a postmenopausal woman where it's increasing in size and the patient's not on hormone therapy, there are more chances that this is going to turn out to be a leiomyosarcoma. The other features which we look at are irregularity. Now in this tumor, you can see a black line surrounding the mass, whereas anteriorly, it's ratty, it's heterogeneous. So those are some of the characteristics which we also look for to differentiate a leiomyosarcoma from a leiomyoma. On the CT scan, it becomes kind of a little difficult. So what we recommend when we see a large heterogeneous mass within the uterus, which looks like a fibroid, we recommend doing an MR. Now, the recent literature says that increased dark areas within the tumor itself, increased vessels will be suggestive of a leiomyosarcoma. Now, PET may not be that good in detecting a leiomyosarcoma because fibroids may also be bright or take up FDG activity in a menstruating female or a female who's on hormone treatment. And it can have cyclic change. Sometimes it may pick up the FDG, sometimes it may not. It doesn't lean it towards one or the other, whether it's a sarcoma or not. Okay, I'm going to stop sharing.
That was very informative, Priya. And, just as Parna said that, these are obviously a very common problem in women, more so in older age group. And not everybody gets imaging, as we have known when we see them after the fact. They've usually had an ultrasound and then they go in for surgery. And then there is this oops kind of a diagnosis that it was not really benign, it was malignant. But again, given the choice, I think MRI seems to be definitely the imaging of choice, especially if you're symptomatic and there is enough concern in the patient to get. With that, I think one of the very, problematic things in this area has been the morcellation or power morcellators, which is why, a lot of women have had to suffer a procedure without and not always knowing the risks involved of that procedure. So we wanted to kind of just discuss that within this group, get the opinion, and I guess it can start with you, Aparna, and then go down the panel to see what else others have to say. But what is the current state of the use of power morcellators? And I know they're doing away with, the recommendation is if you use morcellation, you got to bag it and contain it. But still, what are the risks involved with that? And when would you say is it appropriate to use?
So, I mean, I'll answer your question, but I wanted to give the audience a little bit of a background about where, why we came to this situation, right? So, if you look at the United States, we perform close to 500 to 550,000 hysterectomies every year. So majority of these cases used to be done, and a lot of those, given how common fibroids are, they're done mainly for fibroids, right? So in the past, a lot of these surgeries were done with open, by make the old-fashioned way. You made an incision, and so there was no real, controversy about, trying to remove anything piecemeal. As a technology advanced and we're doing majority of our cases now laparoscopically or robotically, then the question then comes, when you have a big uterus, how do you take it out, right? I mean, most of these uteri come out through the vagina, but if they're huge fibroids, how do you remove them? Or in patients who are having something called a supracervical hysterectomy, where the cervix is left behind and only the uterus is removed, then there's no opening in the vagina to actually remove the uterus. There has to be some way to remove these uterus or the fibroids. And then finally, the patients who are undergoing a myomectomy, where we remove just the fibroid, but leave the uterus behind. Once again, there has to be some way, if you're doing this through tiny incisions, to remove this. So that's where the morcellation of fibroids kind of, came into being. In the past, when these hysterectomies used to be done vaginally, we studied where we would we would cut the uterus in half in the vagina and, remove the uterus piecemeal through the vagina. In that situation, the amount of dissemination, if there was an unsuspected sarcoma, was not that much, because majority of the tissue was actually being removed vaginally. But with all of us, with time, with technology, they tried to find different ways of doing this more efficiently, and that's how power morcellators came into being. So they are basically tools which would actually core out like you would core out an apple. So you kind of put in, it's a little hook that you apply to the fibroid, and then there's like a spinning blade that kind of almost cores the fibroid out and makes it a big round mass, becomes a long strip of tumor. The blades go at a very high speed, and so you can imagine if these are huge fibroids, or if they're fibroids which have calcium in them, they're calcified. So there's small bits of tumor or the fibroid that kind of go all over the abdomen. There's no way to control that. And so that's what was done very, very often, because the thought was that, well, majority of these are benign. So even if there was a little bit of tissue that was left behind, it wouldn't really matter. But we know that, by doing this in women who are not properly screened, you do have a risk of doing this to a cancerous tumor. And so when this happened in 2014, when this was brought to light, the FDA came out with a policy statement which contraindicated the use of power morcellators, which are in any patient who's perimenopausal or postmenopausal, who has a fibroid which cannot be removed en bloc, which means that cannot be removed in one piece. So if you don't think that you can, then in those patients, the power morcellation was completely contraindicated. So that kind of almost encompasses most women, if you think about it, who are having a hysterectomy. So as of today, for many different reasons, for litigation, for hospital policy, I mean, power morcellators are really not freely available. The people who are, the way we are now using, I still do a lot of robotic surgery. I operate on women with big fibroids, and I don't open everyone. So you kind of get around it. I never used a power morcellator, but what we do is we sometimes do the entire hysterectomy or remove the fibroid, and then we make a tiny incision. It's called a mini laparotomy, and then remove the fibroid in one piece. So there's no, there's no contamination of the peritoneal cavity. So that is one way of doing it. One of the other ways of doing is what you brought up is that you remove the fibroid or you put the entire uterus in a big, large bag. So it's a plastic bag that's actually where you put the organ. And then some people will either do a small mini laparotomy, like I said, make a small incision, like a transverse incision, like a bikini cut, and then bring the entire specimen to the abdominal wall and then remove the tumor piecemeal. There are some people who still use a morcellator within the bag. Now, there have been studies, which are small studies, obviously, but they have shown that in spite of doing that, there still is in about 3 to 4% of cases, in spite of taking all the precautions, there still is, the bag can kind of there can be a little nick in the bag. You can get contamination of the peritoneal cavity. So my takeaway with all of this is that I think what Dr. Bhosle brought up was a very good point. When you're thinking of doing surgery for a fibroid, it's extremely important to try to pre-select your patients and kind of get their risk factors to then make your surgical plan. So women who are symptomatic, for example, they're having significantly heavy bleeding, which is out of proportion to the size of the uterus, or who are postmenopausal and have had an increase in the size of their fibroids, whose fibroids haven't really responded at all to any of the previous medical therapies. Those are women that you would think very strongly before trying to cut into the tumor, because there's in the 0.28% of women who will have a sarcoma, those are the ones who are likely to have one.
Yeah, and we're most of the panelists are the ones who are seeing those 0.28% of the patients who come on the other end, and which is why we always cringe at the thought that someone has actually gone in and morcellated their tumor, and we take care of it after. But that was very informative. I moved to, so the biggest thing is, yes, you've done this procedure, now your tumor is out. It's very important to follow up on the pathology of your fibroid, because a lot of times we see patients with, a recurrent mass in their history. They've had a myomectomy or a hysterectomy, and they were not aware that that particular tissue had underlying malignancy. So I direct this question to Inga Marie Schaefer. If you could tell us what are some of the pathologic criteria or the pathology you see, and how do you differentiate between benign versus malignant in terms of your reporting of the tissue diagnosis?
Yeah, thank you so much. So I'm going to try to share my screen with you because I have prepared a few slides as well. Can you see it? All right, so I'm going to talk a little bit about the pathologic diagnosis of uterine soft tissue tumors. Most of them are actually derived from the smooth muscle cells in the myometrium. And this is what we have been talking about today. So these are actually the most common tumors in the uterus in terms of soft tissue tumors. In pathology, we receive tissue, usually from the surgeons, and then we try to establish a diagnosis, and we base our diagnosis on specific criteria that are internationally agreed upon. And we use the WHO classification of human tumors, shown here on the right, to kind of make the diagnosis. And some tumors can be a diagnostic challenge, especially in the uterus. We have a huge variety of tumors that are soft tissue tumors, and I've just listed a few here today for you. We're going to discuss mostly leiomyoma, stump, and leiomyosarcoma, but you can see that the list goes on, and there's actually many more other tumors that also we need to take into consideration when we make a diagnosis. So as we've heard today, uterine leiomyoma or fibroids are very common. Approximately a third of women and up to 70% of women will develop one of these during their lifetime. They can be symptomatic, and I've shown a picture here on the right of the slide, so you can see that these appear kind of white and firm, and they are usually well circumscribed. So the margin of the tumor is an important factor that we take into account for our diagnosis. In pathology, we often say that anything that's very well circumscribed is more likely to be benign than aggressive. So this is an important clue for us. So yeah, when we talk about morcellation, for instance, as a pathologist, we would cringe because we always need to evaluate the margin of a tumor to be sure that, for instance, something is benign, because if we cannot evaluate the margin, we cannot say for sure that this is actually just a leiomyoma. Leiomyomas also can occur in what we call variant forms, and I will show you a few examples on the next slides. About 10% have kind of specific features. I will not go into much detail here. This is something that the pathologists have to struggle with, but just to show you that the spectrum of morphology is also quite wide. So here's an example of a conventional uterine leiomyoma. This is how these tumors look like under the microscope. You can see they are kind of pink. They have a few nuclei. These are these kind of purple dark dots. And this is what they usually look like. But you can see here on the next slide, we have an example of what we call a cellular leiomyoma. And you can appreciate that there are much more of these dark purple dots. So that means the tumor has many more cells per area. And on the right is a leiomyoma that we call atypical. So you can see that these dark dots, the nuclei, all look a little bit different. Some are darker, some are not so dark. So these are tumors where, as a pathologist, you start thinking about, is this really a benign fibroid, or could this be something more aggressive? So then in contrast, what is more aggressive is the uterine leiomyosarcoma, and we've heard today that these account for about 1 to 2% of uterine malignancies. So they are quite rare compared to other tumors, but they are the most common uterine sarcoma. And we always need to keep these in mind. They are more common in elderly women. They also can be symptomatic, and they are often quite large. They can be circumscribed, but oftentimes their margins are more invasive and infiltrative. That means kind of the tumor is kind of growing into the surrounding benign tissue. And this is important for us to see. So if we receive morcellation material, we cannot appreciate that. And that makes it much harder for us to distinguish leiomyoma from leiomyosarcoma. And they can occur in different histologic patterns. And what's important for us in pathology is that we base our diagnosis on 3 features. That is nucleotypia, so how kind of abnormal do the nuclei of the tumor look like. Then we have mitotic index that tells us how fast do these cells divide. And then last, we look for tumor necrosis. And here you see examples of a leiomyosarcoma on the left. At the top, you can see those 2 kind of dark ovoid structures. So this is indicating that the cells is actually dividing. So this is an example of a mitosis. And in pathology, we look for that as a feature that would tell us, okay, this tumor is dividing fast. On the right, you see an example of a pleomorphic leiomyosarcoma. So here you can see that all the cells look really very different. Yeah, the tumor is growing fast and it's poorly differentiated. So this is an example of an aggressive leiomyosarcoma. Because we need to evaluate atypia, necrosis, and the margins as well, it's very important for us to receive what we call the specimen like intact. So we need to have the tumor be resected and not morcellated. Otherwise, it's very hard for us to be sure that we actually can evaluate these criteria. And to make things even more complicated, we can see here, this is just to show you that the leiomyosarcomas all can look very different. And as a pathologist, we need to be trained to recognize these tumors. So on the bottom left, for instance, you can see the tumor has very big cells. At the top right, it's kind of more space in between. So this is a myxoid leiomyosarcoma, but all of them are leiomyosarcomas. So we need to be sure that the diagnosis is correct and recognize these different features. And finally, I won't go into too much detail here, but because pathologists sometimes have problems really distinguishing leiomyoma from leiomyosarcoma, there's a category in between that is called smooth muscle tumor of uncertain malignant potential. These tumors do not recur very often, and they somehow fall in between because they do not fulfill all criteria that we would like to see to call it a leiomyosarcoma. So for instance, they can have necrosis, but otherwise look pretty benign and bland, or they have a high mitotic rate, but then they don't have mitosis and necrosis. And this applies to kind of all tumors that are kind of in between leiomyoma and leiomyosarcoma. And pathologists today are still struggling with a way to better identify these tumors in between and really parse out which of them is actually a leiomyoma and which behaves more aggressive like a leiomyosarcoma. And just by looking at this algorithm, you can see that it's still very complicated for us in pathology to really make that decision. This is a diagnostic tree that a group came up with, but that just illustrates that this is still a topic under discussion, and it's quite controversial even among soft tissue pathologists. Yes.
That was very, very informative. Thank you so much. But again, you made a very good case of, intact tumor tissue being extremely important for you. And just as Dr. Kamath also mentioned, they try to take out the tumor and block whenever possible so that we at least have a diagnosis. So, so coming to patients who might then receive the likely or unexpected news of having malignancy in the tumor that they had resected. So then, what should they do when they get faced with this oops diagnosis that, your tumor actually was malignant? And I'll kind of move to the medical oncologists on the panel and ask them about, what would you recommend to the patients who might watch this video and get a diagnosis of malignancy? I would say myself, I would say make sure you get an expert opinion about what to do next, because surgery alone might not be enough. So I don't know if Meg, would you want to go with what would your recommendation be to someone who's just had a fibroid hysterectomy, either morcellated or not, but got the diagnosis of malignancy?
So I think the first thing we want to know, since now there's a diagnosis of a cancer, is was this just in the uterus or is there disease elsewhere? So the first step that I always take is to stage the patient. And by staging the patient, that means getting scans to make sure there's no disease elsewhere. And where would we look for it? Well, sarcomas can travel to the lung, and that's a very common place that we see disease. But we sometimes also see disease within the abdominal cavity as well. So those are sort of the most common places. So a good CAT scan of the chest, abdomen, and pelvis with contrast is typically the first step that I take.
And Melissa, say if you do the staging and they've been told that there is no disease elsewhere, and Meg can comment after that as well, when would you still recommend that patients see a medical oncologist, and are there certain scenarios in which you would recommend further treatment?
Yeah, that's a great question. And thank you for the invitation, by the way, today. So I think one of the biggest challenges that we have as sarcoma medical oncologists is this exact question. We know that, we're always seeing it on the flip side. I appreciate all of the information today about diagnosing fibroids and how we manage them. But unfortunately, as you mentioned earlier, we always see it in that 0.1, 0.28% of patients who actually have a sarcoma. And what we know is that even when this tumor is confined to the uterus, there's still a very high risk of recurrence, unfortunately. And as Meg mentioned, there are the most common locations would be in the lung or in the abdomen. In fact, the recurrence rate could be as high as 50 to 70%, depending on the case. So there's been a lot of studies done about whether or not we should be giving these patients chemotherapy. Unfortunately, the short answer is that there's not great data to actually recommend patients to have chemotherapy after they have their hysterectomy. Of course, if there was additional disease that we would find on the scan, we would recommend treatment. And I agree with you, Nita, that we would definitely want to make sure that there's a multidisciplinary discussion for the patient by meeting a medical oncologist who has experience with leiomyosarcoma, and meeting with somebody like Dr. Crago or a gynecologic oncologist to have a joint discussion about what to do next.
Yes, absolutely. So the key point is make sure you go meet someone in addition to the gynecologist that might have done the procedure, meet a specific gynecologic oncologist who might then refer you to a medical oncologist, and make sure you have a multidisciplinary team that looks into your case. And there might be cases where chemotherapy after might be recommended given the risk, and in some cases they might be just follow-up. But it'll be important, even if you don't have any additional therapy, that you get followed up so that a recurrence can be picked up. So now I, like to, move to Dr. Crago, because, we do see patients who then have a recurrent, they've had their surgery and they then are presenting with a recurrent mass in their pelvis or sometimes elsewhere. And they sometimes present to the surgeons first because the question is to get them resected. How do you make that decision, and who would be the candidates to undergo repeat surgery, and how do you approach that multidisciplinary decision?
Yep, and that's actually, we often see patients like this. Sometimes, as was mentioned previously, they didn't even realize that there was cancer when they underwent the hysterectomy, and they just come to us with a new mass in the pelvis or other places in the abdomen. So one of the first things we do is try and determine if that's related to the original hysterectomy, and so we'll often re-review those slides. The problem with surgery when these tumors come back, each time we do an operation, we not only create scar tissue on the wall of the abdomen, but we also create scar tissue inside the abdomen. And so if, for example, you've undergone a hysterectomy, oftentimes the places that the tumor recurs are around where the uterus was, which is also the place that you develop scar tissue. And so that scar tissue develops between the surgical bed and the nearby organs like the bladder or the rectum, other pieces of small bowel. So it can make repeat surgery quite difficult. Sometimes it's very straightforward. A tumor only involves a small piece of the bowel that we can cut out and put back together, but often the surgeries for recurrent disease can be difficult. So we have to be very careful about who we select for surgery, because the worst thing to do is to put somebody through a major operation, which may require a resection of the bladder or a colostomy, for example, and then have the tumor come right back. So what we want to determine is the things that are good prognostic features for us as far as determining who is best for surgery is if the tumor has only come back in one place. That's much better than if it's come back in 3 or 4 or 5 or 6 places, because in the cases where it's coming back in multiple places, we worry that not only are there the sites we can see, but that there also are probably other cells and smaller tumors that we can't see on a CAT scan yet that maybe are just going to regrow after start regrowing as soon as we take out the tumors we can see. So fewer sites of recurrence are a good sign. The longer between the hysterectomy and the site and the recurrence, that's also a better sign as far as who should have surgery. And that's because it often means that the biology of the tumor is that it's growing back slowly. So even if there are other small sites of tumor that we can't see when we go and we do the operation, if the biology is that the tumor is going to grow slowly, then those sites often won't come back for long periods of time. So those are really the two main things that we're thinking about as far as when we're going to choose or recommend that somebody undergo a surgery, particularly if it might have a lot of side effects. And then the other thing, of course, is if those tumors are causing symptoms, then often we'll be more aggressive about surgery, because if it's causing a bowel blockage or problems with one of the with the bladder, then we may be more likely to be a little bit more aggressive about surgery, just because we want to go in and relieve that symptom if we think that chemotherapy up front may not help very much. So those are really some of the main considerations as far as when a tumor comes back in the abdomen, who do we take for surgery versus who do we refer for chemotherapy. Those patients who have tumors that come back much quicker or more in places, we're more likely to refer and get input from our medical oncologists about which systemic therapies may be more effective than surgery alone.
Right. Thank you. Thanks, Amy, for that. So, I mean, just kind of as we're wrapping up, I think the one most important thing that we'd want our viewers to be aware of, especially those who don't have a diagnosis of cancer yet, is how do they go about the informed consent process, because just as we heard through this discussion, fibroids are very common, and there are actually many different ways of treating fibroids, whether it be just with medical therapy, medication, or surgical approaches. And choosing patients for them appropriately is important. So what is key is that patients know what procedure they're being offered by their gynecologist, and they have full awareness of what are the risks associated with that particular procedure. I mean, especially if morcellation is being offered, you would want most patients to have a very good understanding of what they're going into before they undergo that procedure. So I would just, invite comments from the panel about the informed consent process. Otherwise, I will pick on people. But just, we all have our ways of when we're telling patients about the treatments we're going to offer. But just, comments to the public to say, patients, what do you want them to know, and what should they be questioning their gynecologist as they're signing consent for these procedures?
I guess I could take that. I'm a GYN oncologist, so I sort of am, the person I see after patients have had some of these procedures done. But I think one of the questions that had been asked before, or one of the reasons we actually got into this situation, is because, I think people and gynecologists to a large extent do take fibroids very, they just kind of take it as routine because because of the how common they are. So even women who are postmenopausal who have bleeding but they have fibroids are just told that, well, it's just your fibroids. So I think it's extremely important for patients to kind of know, number one, what they're, what type of procedure they're going to have. Number two, for example, is it going to be a complete hysterectomy? In which way are the fibroids going to be, or the uterus going to be removed? So is it going to be done vaginally? If the uterus is too big to be removed vaginally, how is that going to be removed? Is it going to be cut in the vagina, or it's called bivalving the uterus? Or is there going to be a small transverse incision, a mini laparotomy that is done to remove it? And then obviously, like you said, if morcellation is offered, especially for patients who are undergoing what we call a supracervical hysterectomy or a myomectomy. And that is something that has to be, patients really need to be educated, that they need to ask a lot of questions about how this is done. Because when we see patients who've had some of these procedures done, what the patients are told and what the operative note from the GYN, the gynecologist who did the surgery, are very different. So it's very important to kind of ask those questions. I think with all the the press beyond that is around the morcellation, I think a lot of patients are already getting more educated about morcellation. But I think, to me, when you're going into surgery for whatever reason, I think it is really up to you to ask the questions. If you don't get the answers that make sense, to ask them again, and just kind of educate yourself exactly how this procedure is going to be done.
And that's a good point. It's about educating yourselves beforehand, because there's some gynecologists who might favor one procedure over others based on their expertise. And so it's important to know what are the other options that you might have in addition to the one that's being offered. Right.
Just add one more thing, like if something doesn't, if you don't come out of that consultation with a complete understanding, it is completely okay to get a second opinion, in my opinion. So, I mean, I think that, before venturing into any major surgery, it is very important to understand what you're going to expect, because you have to know what you're getting yourself into. So if something doesn't quite make sense, I always tell patients, go get a second opinion. It's important to hear from more than one person, like we are. We're a panel of people, and you may get a different opinion, a different approach that may be feasible. So I think that's also something I think is extremely important.
I'd like to, in interest of time, also move to Cecilia, who's a nurse navigator. And, I think patients are, often are not well versed with all these options and all the different specialists whom they have to see even after they get a diagnosis of, say, malignancy in their tissue. So what is the role of a nurse navigator? And, perhaps that there are some people they can reach out to in the system to try and help them navigate between these various specialties and can help them. So Cecilia, in your experience, what are the common issues that patients have faced, and what would you advise them when they're in that situation after a diagnosis of a potential malignancy?
Hi. Oh, thank you for having me. So normally we just, we'd get a new patient, and then we'd kind of refer if we need to. And so a lot of it is just like availability. Support, I believe, is really important as well for the patient to have support. So just trying to help them get from, seeing a gynecologist or a gynecologist to getting them scheduled for surgery, to getting them cleared for surgery with, depending on the medical history of cardiac clearances, medical clearances, neurology clearances, and just kind of help the patient make those different appointments if they're not able to do so themselves, just so that we don't have any kind of delay in their care. So I believe that's very important to have a support person that if they can't, do it on their own, that they have somebody that can kind of help guide and make those appointments for them. Also getting like insurance authorizations for the different imaging, the MRIs, the CT scans, and helping them schedule those appointments, as well as, some patients need help with getting transportation to these different appointments because family members are working or, whatever other reason that they have. So our job is very important as well, just to make sure that the patients get from point A to point B with little to no delay as much as possible.
That's an important point, is just that if you are not getting an answer, if you're finding it difficult, make sure you reach out, because every office has resources to help you with this navigation and making sure you get the required appointments scheduled. Before we take questions, I would like to invite Nikki Hughes to share her story with everyone in the panel and the audience, and then we will take questions after that.
Hi, I had a fibroid for 6 years, and I did end up having morcellation, and it was a leiomyosarcoma. So in that 6 years, I did see 4 different gynecologists, and back at the beginning of the program when we talked about imaging, only had an ultrasound. So I would have loved for someone else to mention having an MRI or a CT, but like I said, I did see multiple doctors, and the ultrasound was kind of the end all be all. It's a fibroid. And then I proactively sought out a gynecologist that would do a laparoscopic procedure. I didn't know about morcellation, so I didn't seek that out, but I did want a myomectomy because I didn't want to lose my uterus just because I just didn't want to. I wasn't going to have any more kids. I made that very clear with my doctor. And I was not menopausal. So I really wasn't a candidate in hindsight learning about morcellation, but the first time he mentioned morcellation was during the consent. So it's really hard to do the research and the education when you don't know what you're educating, other than I did do research on myomectomies. And so it's great to educate yourself as a patient, but there's a lot of things out there that you don't know that you're gonna find out in hindsight. The bag, all that kind of information. So really, ultimately, I put this in the gynecologist's hands. They need to basically not do it. It's a horrible procedure. But, after the fact, programs like this are great as far as educating people on what they need to do once they have a cancer diagnosis. I'm a nurse. I'm very proactive on learning what needs to be done for me. I didn't have a nurse navigator, which I think is a wonderful thing, and I'm glad they're out there. But since I was so proactive, I was able to get my second opinions and find out what I needed to do for myself. But there's so many great resources out there for patients, social workers. Integrative medicine is awesome, working with your sarcoma specialist. There's radiation oncologists, the surgical oncologists, just a lot of different things that I found out on my own through research. that patients have, a lot of major hospitals, patients will have access to those type of individuals that can help them to get as much support and care to help them through this journey, because it's tough, and I wish everybody the best who's going through it.
Yes, thank you so much, Nikki, for sharing that. But you're right, you get the perspective, and I hope people hear it, because when you're on the other end, you're not thinking of cancer. So you're thinking of how do you save your uterus and trying to figure out how you can get it done the easiest, and just being aware. And that's what we're trying to do, is just increase awareness so people ask questions, because, and that way raise it with their gynecologist, make sure they know the other options, and make sure they know the risks of the procedure. Question for the panel from Deborah Gates.
And I'm Deborah Gates out in Washington State. And the panel I have is about the appropriate procedure, looking at the standards in 1997, whether I was an appropriate candidate for a manual morcellation. I was 42 years old. I had bleeding. I had a lot of bleeding, but I simply used lots of menstrual pads and wore a black skirt or black pants to hide the fact that I would leak out. But I was, that was the issue. I was one of the top executives in a large energy company, so I was a very busy girl. And my anesthesiologist husband pointed out to me that I looked like I was pregnant, because my uterus had grown to the size of a 16-week pregnancy with the fibroids. And he brought home an internal medicine textbook which showed that a record fibroid had grown to 150 pounds when they removed it. So I did agree to have a hysterectomy. As a physician wife, our friends were physicians. So Barbara, a gynecologist, said that she did did vaginal hysterectomies with morcellation, even if I don't think she used the word morcellation, but she said she could remove uterus and tumors even when the uterus was even bigger than mine. It just had to be mobile. And she said I was mobile. And I signed a consent form that said she could do a vaginal hysterectomy or she could do an abdominal one. There was nothing about the risk of cancer. But again, we're in 1997. So my anesthesiologist provided Barbara all the radiology imaging and all the information in terms of my medical records. And of course, she did manual morcellation. She went in vaginally, cut everything up into 37 pieces and removed it. And then the pathology report had a surprise finding of uterine leiomyosarcoma. Barbara's comments were that I shouldn't freak out. And then, of course, my tumors were sent around the world. I don't want to enable bad behavior. So the subsequent pathologist said, oh, yes, clinical follow-up needed. And so I did end up talking to, or my husband ended up talking to Dana-Farber, Sloan Kettering, and we had the issue of whether my ovaries should be removed. But my question for the panel was, back in 1997, and that was 23 years ago, was this the appropriate procedure? So I'm just curious whether that was appropriate back then, knowing that the standards of care has drastically changed, and how I wish I'd had a copy of this video, before I was looking at getting my fibroids removed. So I commend everyone involved with this video.
Well, probably be difficult to comment in 1997, but I don't know if any of the panelists have any, comments to make on that. That's the thing we're discussing, that this, it was a technique that was used, and up until when Aparna, Dr. Kamath mentioned, I think it was in 2014, the risks really didn't come out or weren't as prevalent. So most of the gynecologists who were trained in this were using it quite often.
Well, I think what was interesting here in retrospect was that the imaging was showing a rapidly growing uterus and fibroids. Over 6 months, it about doubled in size. And hindsight's 2020, and looking back, that's, to me, as I'm not a physician, but I come from a family of physicians, that should have been a red flag. I was 42 years old.
So oh, sorry.
Go ahead.
I wanted to address your question actually, because I think one of the things that we were always taught in medical school was, or in residency was that, if you have a fibroid, just like you said, which is rapidly growing, if it grows, doubles in size in 3 to 6 months, so increases the size by a size of a 6-month pregnancy in over a year, then those are considered to be, concerning for cancers. Huge studies have been done, and we now know that that's not true. So that's, fibroids that suddenly increase in size, especially in premenopausal women, you are premenopausal, don't really indicate that this could be a sarcoma. So that's not really the reason not to have had morcellation. I mean, I think that the reason not to have done a morcellation for you is probably because of the size of the tumor. I mean, I think that when you have something that big, you don't know, when you're doing a vaginal hysterectomy, it's literally kind of almost a blind surgery, because we don't know where the ureters, so the kidney tubes are. They're very close to the cervix when there's a uterus which is that large. I've had so many patients who've had a vaginal hysterectomy, and then because the uterus was so distorted, have had the ureter nicked. So I mean, I think that when we decide whether it was 1997 or now, the incidence of sarcoma, of a leiomyosarcoma that was found incidentally, has not changed. It's the same incidence. So it was the same incidence when you had your surgery, it's the same incidence now. So I think that just having a high suspicion, doing things which will not compromise the integrity of tissue, I think those are good principles by which to go by when you're planning surgery.
Before I read out another question, thanks Aparna for that. I know if Suzanne George, if you're on, we would love to hear your comments about this topic, about what happens when they do get a diagnosis of malignancy, because we discussed that earlier, and comments about the informed consent process and what advice you have for patients out there.
She was online, but I don't see her now.
Okay, then we can just go on to the other questions. I also had a suspicion because I couldn't see her picture. So, Jeff Wade had a good question here saying that, so these difficult decisions, are these difficult decisions recommendations determined usually within a multidisciplinary medical team? And I wonder if Jeff is talking about when you're talking about treating fibroids that have been diagnosed, or when you have a diagnosis of sarcoma. So I can, and we can answer both those questions. I don't know if gynecologists operate with a multidisciplinary medical team, but I can have either Aparna, if you want to take that, and then I can have Meg or Melissa address the sarcoma diagnosis and multidisciplinary team.
No, so in most gynecologists will see see a patient, and in most cases will kind of make the decision of what to do without really, I don't think there's a lot of consultation. If it's a really tricky case, they may discuss it with a partner. But in general, a lot of these are, decisions that are made by that particular gynecologist. And what you said, Neeta, is a lot of what we present to our patients is also what is our expertise. So if someone you see is a laparoscopic or robotic surgeon, then they're more likely to present that option versus someone who's an open surgeon. So I think it goes back to the same situation. I think it's very important, if you're not 100% sure, if it's not clear cut, to get a second opinion.
And I think we're almost on our end of time. So Meg, if you want to comment about multidisciplinary treatment of sarcomas, and then we can then have all the other questions answered via email. Annie, you can send them to Annie, and we'd be happy to answer them through the panel for you later.
Multidisciplinary care in sarcoma is exceedingly important. There are a number of reasons. One, it gives us the opportunity to review the pathology, and the pathologists are part of that team. It's not just the clinicians. We also have the radiologists who review the scans with us. So we really get an understanding of what this tumor looks like at sort of the cellular level, to think back to what Inga Marie Schaefer mentioned, but then also what does the tumor look like? Each physician, as was mentioned, when you see a patient, you end up with your expertise as the thing that comes first to mind. But it's also important to remember that there are other things, surgery, potentially radiation, and not forget those, and have those experts weigh in on the role that they might have to help with this patient.
Well, thank you so much, Meg. I would like to end this webinar and thank all our panelists, our expert panelists who shared their opinions. And I really hope that this can reach a lot of women out there who are at risk for sarcoma. Again, just, it's very difficult to know who's at risk. So if you have fibroids, just make sure you know your options, make sure you ask questions. And we'll be happy to take any additional questions through Annie via email. Thank you all.
Dr. Samaya?
Yes.
I'd just like to thank you as the panel moderator and all the gracious panel members who came together to share their expertise in their respective fields for audience participation and creating a proactive arena to help them establish, better understanding of treatment approaches to build awareness and strengthen their self-advocacy in order for them to be positioned to make well-informed decisions in their healthcare in the future. And I just thank everyone for coming together on behalf of the foundation. And thank you ever so much for your time.
Thank you so much for organizing and for having us.
Thanks,
Thank
Annie,
you
for your
all.
continued advocacy for patients.
Thank you so much. We couldn't do it without you. We're just in lockstep to work together and to support you all, as well as research clinicians. We really are grateful to you and all the work that you do for so many.
Thank you.
Thank you.
Thank you.
Thank you. Thank you all.